everyone, I'm Dr. Monica Barne. I head the Training Programs Division at Chest Research Foundation, and I'm going to speak to you about clinical features and pathophysiology of asthma. You might wonder, why clinical features with pathophysiology? Don't we all know that the clinical features of asthma are cough, breathlessness and wheeze? Then why do we need to club it with pathophysiology? Well, what is important for us to know is that the typical pathophysiology and the changes that occurs within the airways are what gives rise to the clinical symptoms of asthma. And when we understand what happens within the airways is when we will be able to target that particular pathophysiology with correct treatment. And that's the reason we club the clinical features with pathophysiology. We all know that when a patient comes to us in an acute attack of asthma, the patient comes with breathlessness, wheeze, cough, and chest tightness. And this is a very common scenario that we see in our clinical practice. In these cases, what do? We know that the symptoms are because of bronchoconstriction. So we treat this bronchoconstriction with bronchodilators, either in the nebulized form or orals or maybe even injectables in some cases. And we take care of this bronchoconstriction. But what I would like to draw your attention to something over and above bronchoconstriction that happens in the asthmatic airways, which is in turn responsible for the bronchoconstriction and all the other symptoms of asthma. So if you look at this diagram, on the left hand side we have a normal airway like this, and on the right hand side we have an airway which is constricted, if you may appreciate the bronchoconstriction. There is a lot of inflammation within the mucosa, and there is a lot of mucus production and mucus secretion that is happening. This is the condition that typically happens in an airway when the patient is suffering from an acute exacerbation of asthma. And what we usually do is we give the patient bronchodilators and we relieve the symptoms of the patient. But with bronchodilators, which we usually give by nebulized form or tablets or syrups, what we are doing is we are only taking care of the bronchoconstriction part. But what remains, the bronchoconstriction gets relieved, but what remains is the inflammation. So there is always some amount of persistent inflammation in the airways that remains, which gives rise to the hallmark of asthma, and that is bronchial hyperresponsiveness. The bronchial hyperresponsiveness, I would like to explain it to you with the help of the example of Mimosa pudica or the touch-me-not plant. We know that when we touch other plants, nothing happens. But the moment we touch the Mimosa pudica plant, the leaves just close themselves. The leaves are hypersensitive, they are hyperreactive. So we call asthma as a personality disorder of the airways, in which the airways are hyperreactive to various kinds of triggers. This is the hallmark feature of asthma, bronchial hyperresponsiveness. And the inflammation that gives rise to the bronchial hyperresponsiveness is characteristic in the sense that it is always minimally persistent. So it is not that an asthmatic is breathing an air which is full of triggers and a non-asthmatic is breathing air where there are no triggers. We all are breathing the same air. But in a normal individual, if you look at the left side of the diagram, if the individual breathes in any triggers like smoke or pollen, there's little inflammation that happens in the airways, and that pollen is eliminated, that trigger is eliminated. But in an asthmatic airway, because there is always a huge amount of persistent inflammation, the triggers when they come, they give rise to symptoms of cough, breathlessness and wheeze. So if you look at the right hand side of the diagram, the inflammation of the asthmatic airways is much higher and it is persistent. It is what makes the airways hyper-responsive. It's almost like, suppose I have a burn injury over here. If I hit myself on this hand, nothing will happen. But I have a burn injury, it's already inflamed. If I hit myself here, I'm going to hyper-respond. That's what happens in the asthmatic airways. Now, another characteristic of this asthmatic inflammation is that it is variable, meaning that it can increase and decrease spontaneously on its own. So if you see the middle portion on the right hand side, the inflammation has reduced. So there is a huge amount of trigger there, but still the patient is not getting any symptoms. You will get patients typically telling you that, doctor, I'm perfectly fine in summers. I don't get any symptoms in summers. But moment it is a rainy season or winters, I get symptoms. Because it is in these seasons or during the change of season, the inflammation increases, and then even with a small amount of trigger, the patient precipitates with symptoms. So this is a characteristic feature of asthma inflammation. Firstly, it is persistent, and secondly, it is highly variable. Okay. Now, let us look at this airways. We saw that we treated it only with bronchodilators and maybe a short course of oral steroids, but the inflammation persisted. So the moment this inflammation is exposed to any trigger like smoke or dust or change of weather, for some people it is eating cold items, the cold temperature, the patient will immediately go back and have an acute attack of asthma because of this persistent minimal inflammation. Okay? And the patient's airways will never come back to normal. An inflamed airway is like a loaded pistol. Only a trigger has to be fired to trigger off an episode of acute bronchoconstriction and an acute exacerbation of asthma. Okay? I would like to mention over here that even when the patient has got this persistent inflammation, many times the patient is free of symptoms, but sometimes the patient still gets some symptoms. Especially in children, if you see, the persistent inflammation, the moment the child is exposed to change of weather or any cold items, the child will get an acute attack of cough, breathlessness and wheeze. But in between this, when there is minimal persistent inflammation, the patient can still get some symptoms. And those are cough while running, cough while climbing stairs, or even breathlessness while climbing a little bit of stairs, or even cough on crying, because laughing, crying, running, climbing stairs, they are all exercise for children. Even in adults, you may find adults reporting that when they are not in an acute exacerbation, they would still find it difficult to walk fast or climb up staircase, especially when the inflammation is persistent. Okay? In children, typically, what I would like to draw your attention to is 80% of children have only cough as the presenting symptom of asthma. They may never have a breathlessness episode, or they may never wheeze. Typically, the parents will report that the child comes down with recurrent episodes of cough which is dry, persistent, more at night, and the child coughs and sometimes ends up vomiting out a little bit of sputum, because the sputum of asthma is very thick and viscous. It does not come out easily. So after that little bit of sputum comes out, it's only then that the child feels better. So if you have a child who presents with this kind of symptoms, you must think of asthma. Of course, there are a few associated things that go with it, like family history of asthma, or history of eczema in the child, or history of atopy like allergic rhinitis, allergic rhinoconjunctivitis, eczema in the child or in the family. So a child who's presenting with recurrent coughs, do not just consider it that it might be a lowered immunity, which we often think, or it might be something that the child will just grow out of it after the child reaches 5 years of age. No, that's not the fact. We know that it could be asthma, and we should put the child on appropriate treatment of asthma so that we can relieve the child of the symptoms and give the child a normal childhood back, where the child does not suffer repeatedly. Okay, so this is something that we need to keep our eyes and mind open to and ask in the history. Now, coming back to the persistent inflammation, whenever we have triggers like dust, smoke, change in weather, etc., the patient will come back with an acute episode. And typically we have this kind of a presenting feature in the clinic. What we have to do is we have to give back a normal airways to the patient. And how do you do that? I'll come back to that shortly. But a word about the inflammation. There are a lot of inflammatory mediators and markers and cells that are implicated in the inflammation of asthma. The eosinophils, the Th2 type of cells, the mast cells, their role has been researched and identified over the period of time, and now we believe that it's the Th2 type of immunity which is responsible, and it gives rise to different types of inflammatory mediators and markers that I have enlisted over here. But I would like to draw your attention to the fact that leukotrienes are only one small part of this entire gamut of inflammation. And if you are aware that anti-leukotrienes are also a modality of treatment, they are also categorized as controllers. But if you give anti-leukotrienes, that is montelukast, only as monotherapy for treatment of asthma, you are targeting only that small element of asthma inflammation as is depicted, and the rest of the inflammation is not taken care of. What is it that will take care of this entire gamut of inflammation? It is steroids. And when we talk steroids for asthma, it is always inhaled corticosteroids, except for in an acute exacerbation when we might have to give a short course of oral steroid. But inhaled corticosteroids are the mainstay of asthma treatment, inhaled not with a nebulizer but with inhaler devices, which we will be learning about in the later parts of this module. So inhaled corticosteroids are the mainstay of asthma therapy. What happens if we don't control the inflammation and we allow the patient to keep on switching between an asthmatic airway and a partly controlled airway where we have just given bronchodilation but the inflammation still persists? The patient keeps switching between an inflamed and non-inflamed condition, or a bronchoconstricted and bronchorelaxed condition. And this switch between the two conditions leads to something that is called as airways remodeling. In airways remodeling, what happens is there is epithelial desquamation, there is subepithelial deposition of collagen tissue, and there is hypertrophy and hyperplasia of the smooth muscles. To explain it to the patients, what we often do is we tell them that if there is an injury, the skin will heal with scar formation. So the collagen deposition is something like that. Again, when the patient or when any individual exercises, what he or she does is contracts and relaxes the muscles. Something like that happens in the airways, that the muscles, because of repeated contraction and relaxation, undergo hypertrophy and hyperplasia. Well, the mechanism is not that simple, but this is so that we can explain it to our patients. So this subepithelial collagen deposition and the hypertrophy and hyperplasia of the smooth muscles together lead to permanent changes in the airways, which we call as airways remodeling, and that is what leads to an airways that does not then respond to the standard treatment of asthma, and it becomes non-responsive to normal bronchodilators. The patient develops fixed airways obstruction, which is something like COPD. So the patient develops COPD, and in our country, uncontrolled asthma is one of the major causes of COPD. So what we as physicians have to do is, the moment we have diagnosed the patient as asthma, we have to put the patient on inhaled corticosteroids using inhalers. So the take-home messages from my presentation are that the hallmark of asthma is bronchial hyperresponsiveness. The basic pathology of asthma is inflammation. The inflammation of asthma is highly variable and it responds very well to inhaled corticosteroids. So we should initiate inhaled corticosteroids as soon as we have made a diagnosis of asthma. Once the inflammation is controlled, the airways will come back to this normal position where we see that there is no inflammation, no bronchoconstriction, and the frequency of attacks and the severity of attacks will definitely go down. Otherwise, uncontrolled asthma can lead to remodeling and permanent changes in the airways, which can lead to a COPD phenotype. Thank you all very much.